Thank you. Thank you very much. It's always great to come back. You know, I lived here in Asheville for 25 years, represented the area in the legislature I was elected to 4 terms before I made the decision to move over to Health and Human Services, an area that I greatly enjoyed. And as you went around the room and introduced yourselves and named the organizations, it brought back a lot of memories of things over the years that I've been involved with. I was the first chair of the Care Partners Board whenever we first pulled all that together, and have worked with many of you. And obviously Nathan knew him he kind of followed me from after I left the legislature and came down and worked with him. So it's great to be here and kind of bring you up to date. I have, as Leanne mentioned, since I left as secretary now almost 7 years ago, have kind of brought in folks who were leaving the department with a lot of background and experience, and created a kind of a consulting firm that works in the whole health and human services arena, including past interim and deputy director of Medicaid, past interim and deputy director of mental health, past deputy secretary and director of social services, and about 10 or 11 other folks. And so we've got a good crew, and we try to stay very up on what's going on, because it is an interesting time, and I'm convinced that everything going on right now will carry me right into retirement, whenever that may decide to do that one of these days. But anyway, thanks for inviting me. And what I want to do is one, just kind of an update on where we are. And I don't know how much, I'm sure all of you kind of follow this, but how much in-depth knowledge you may have, I don't know. So if I'm telling you something that everybody already knows about, just say move on to the next thing, and that's what I'll do. And if you have questions along the way, feel free to do that. But the whole Medicaid reform, and keep in mind, Medicaid actually covers somewhere between 16 and 18% of the people in the state. Larger pockets in some areas than in others. And so it is a major piece of the healthcare market in North Carolina. And healthcare is big business in North Carolina, big business nationally. We keep working on how do we control cost of healthcare, keep our insurance costs down and all that. Well, the challenge we have in doing that is the fact that healthcare makes up about 18% of our gross domestic product. It's almost 1/5 of our economy. And it's hard to get your hands around something that big and that big a piece of your economy and say, okay, now we're going to control the growth of this program. I've had the opportunity in the last 10 years to travel to some other countries and do some things around healthcare, and I've seen how they work there and how they work here. There's some good things about the way we do it, but in most countries, healthcare is not the big business it is here, and that makes it difficult to control. So we keep looking at different things that we can do to try to control it. And I mentioned being in big business in North Carolina, it is in the top 5 employers in 65 of our 100 counties. And it's in top 10 employers in 85 of our 100 counties. So when you start talking about how do we control that cost, we're also talking about economic impact and job impact. My hope is that we don't try to decrease the cost, but what we try to do is find ways to keep it from expanding as rapidly as it has, because we're headed towards 20% of gross domestic product where we are right now. So what really led to the Medicaid reform was cost control. The legislature, when the McCrory administration came in, decided they wanted to do Medicaid reform because they wanted a dependable budget for Medicaid. I can explain to them, and have explained to them actually, why the Medicaid budget has not been as controlled as what they wanted. And the big thing that pushed them into this back in 2015, 14-15, was that they came into town, McCrory came into town, and they had a big deficit in Medicaid of like about $400 million, $500 million. It was significant. But in reality, the Medicaid program in North Carolina's growth has been and was, during the depths of the recession, among the lowest in the nation. And the problem with the budget in Medicaid was that whenever the economy is good, the federal match goes down. And when the economy is bad, the federal match goes up. So when we went into 2008, the federal match was growing because the economy was slipping into recession. And as the federal match grew, the legislature took the extra dollars they had and cut Medicaid and did other things. And then whenever the federal match started dropping, they had to make up that amount. So what happened was, and what I've suggested to legislators now, is whenever you have a federal match change, whenever the match is going up, if you want to reduce the dollars going into Medicaid, fine, but make it non-recurring cuts. So that, which means it's a one-time cut, it's still there the next year. And that way, whenever the match comes down, you've already got the money in place and you're not scrambling trying to fill a $500 million hole, which is kind of what happened. So, but that led to the idea of Medicaid reform or Medicaid transformation, and that is kind of what got the ball moving. But now, since that has happened, as they have developed the actual plan for the waiver, it's a Medicaid waiver, and if you don't understand, Medicaid operates under a set of rules. It's basically fee-for-service the way we've always done it. But they do allow, the federal government allows us to submit a waiver asking them to waive certain rules so we can do something different. And so the waiver we've done allows us to go into a managed care capitated arrangement where we have the ability to let insurance companies basically administer the Medicaid program in the state. Most of the states have done that. We're one of the last to do it, but we're going to submit this waiver. But as a part of that waiver, they talked about how in doing this waiver and giving us some flexibility from the old system, that we may be able to do some things to better improve the quality of care, the outcomes, improve health. And so things that in the past Medicaid basically couldn't pay for or couldn't do, under Medicaid reform, we're going to have some opportunities to do some things differently. And that's going to be the real positive of doing all this, with the intent along the way of doing these things differently will also lead to a more controlled spending on Medicaid dollars and the budgeting of Medicaid. So the idea is that we have innovation in the program, that we look at whole person care, that we create a well-coordinated system of care, and we look beyond just treating the problem to trying to avoid the problem in the first place or avoid the issues. And that's where we're going to get. Now, beyond that basic idea, they are going to be doing some things differently around mental health. Right now, you know, mental health here in Western North Carolina, VIA basically manages all the Medicaid mental health dollars and state mental health dollars. And effective with this transition, VIA will start transitioning, and I'll explain that, start transitioning into a tailored plan that will be tailored to deal with the most serious mental illness, substance use disorders, and IDD, intellectual and developmental disabilities. They will no longer control all the Medicaid dollars for mental health. Anyone with mild to moderate issues will move over to what we are calling the standard plans, the insurance companies. And so we'll see a difference there, but the idea being that the tailored plans, VIA likely being one of them, that the tailored plans will have expertise in managing these very most difficult populations. And they will have responsibility not just for the behavioral health dollars, but they'll have responsibility for whole person care, that they will get the dollars to do both the physical as well as behavioral health, so it's better coordinated. So that's one thing. Secondly, they're really putting a focus in this on developing things around the opioid epidemic and dealing with those. That's going to be a part of it as well. And they're also going to look at what's going to probably impact most of you in this room more than anything else, is the whole of social determinants of health and how we're going to use those kind of things in order to, or address those kind of things in order to try to reduce healthcare costs. You've probably all heard, as you've heard conversations about the issue of social determinants of health, how we're going to try to address that. And so there's a couple things going on. As we begin our transitioning into Medicaid reform, and we'll have the first transition with about 27 counties, northern counties that run from some of the mountain counties across Winston-Salem, Greensboro, Durham, Raleigh, that area. We will start transitioning folks into those areas on November 1st, if everything goes well. And there's some issues right now that could slow it down, but I don't think so. So that starts November 1st, and basically transitioning initially is going to be women and children because there's some carve-outs, some delays. Aged and disabled to a great degree will be delayed. Dual eligibles, people covered by Medicare and Medicaid, will be delayed. Folks in skilled nursing facilities for a certain period of time will be delayed. They will continue to get fee-for-service. But as we develop this, and the idea being, let's wait and bring in the most difficult chronic cases after we've got our feet on the ground and we know the system's working okay. So November 1, they bring in about 27 counties. If all that goes well, February 1, 2020, they bring in the rest of the counties. We have 5 insurance organizations that's going to be doing this, that won the contracts. Blue Cross Blue Shield working with the Anthem, which is the large Blue Cross Blue Shield organization, is doing one of the contracts. AmeriHealth Caritas, a nonprofit out of Pennsylvania that works in about 17 states, is doing one of the contracts. WellCare, another organization that has just been acquired by a company called Centene, has one of the contracts, and they're in a number of states. And then the last one is going to be regional. It's called Carolina Complete Health, which is a partnership between the North Carolina Medical Society and Centene, and they will be doing a regional contract which will start next February, and it basically runs from Catawba, Cleveland County, southern counties down to Wilmington, so it includes Charlotte and those areas. And that will start next November. So we have those 5 organizations, and they are going to have to provide all the basic services, but then they're going to have some flexibility in the things that they do. And some of you as providers that may be Medicaid providers may have heard from some of them already. But what they're going to be doing is looking for how to improve health and control their cost. As some states have gone to Medicaid managed care, they've gone in where there's been no case management, no nothing, and so there's been a lot of low-hanging fruit for them to try to make it work financially. We've had North Carolina, Community Care of North Carolina, and care programs across the state, 16 of them related to community care. Had one here in Western North Carolina. Over the years, they've done a pretty good job of trying to help control chronic disease, work with children with chronic disease, keep people out of emergency departments, et cetera, primary care network. Other states haven't had that, so the managed care companies coming into North Carolina will not have the same low-hanging fruit here that they may have had in other states. So they're going to be a little more challenged, in my opinion, to be able to make this work as well as they're going to hope it works. And in North Carolina, we're requiring that they have an 89% medical loss ratio, which means they've got to spend at least that amount of money on services and not less than that. So they're going to be looking to see how do we better manage the care and how do we deal with these folks. Now, again, the aged and disabled to a great extent is going to be delayed for 2 to 5 years. No longer than 5, and they're going to start phasing that in at about 2. And so some of the population that you work with is not going to be under Medicaid managed care for a period of time. So all this is transitional, absent something else happening. They decide to speed it up, and they can speed it up if things are going well. But under the plan that they've submitted and approved by the federal government, they've got to have everybody in within that total 5-year period. So November 1, they start transitioning. February 1 of next year, they finish the transition. Roughly a year after that, probably July 1 of 2021, the tailored plans begin their work on the serious mental illness, substance use disorder, and IDD. and focused on that and with the full requirements, and probably starting about that same time and phasing in over several years the aged and disabled. The rest of them, the dual eligibles, nursing home folks, et cetera, will also move in. So the companies are coming in, and when they're looking at the aging population, we're a little different than some states. We have our home care agencies. We have our assisted living, or what's been adult care homes in our state. We have skilled nursing, so we have several long-term care kind of capabilities. In many states, assisted living plays no real role in Medicaid at all. They have, in those states, more often intermediate care facilities, which is a step down from skilled nursing. We don't do that in North Carolina except in the IDDMR world. And so assisted living fills the gap, and so trying to figure out, since a part of their funding, about 40%, is personal care services, which is Medicaid, and the rest of the funding is state county special assistance, which is non-Medicaid, trying to figure out how they fit into that continuum of care. So that's a conversation that is going on right now. So anyway, we go through the transitions, and we then will be there, and some of the managed care companies will be looking at things around social determinants short term. I have our group of AAAs from across the state have met with most of those organizations and had conversations, and some very enthused, others enthused, but maybe less so. The ones that are very enthused are the ones that's actually had experience doing this in other states. And I think we have one more yet I've got to get worked out where we have that conversation of how we can work together and make these things work, because they really understand that the social determinants is going to play a big role in them being able to control cost. And you've probably seen examples. Matter of fact, when I was still secretary, this was not with aging, but this was a younger child. It was a 12-year-old girl that ended up being in the emergency department 2 or 3 times a year with asthma attacks. Same thing can happen with seniors. But she was there 3 or 4 times a year with asthma attacks. And the doctor had just been, when she comes in, okay, treat her, get her better, send her back home. And finally, because of working with some social workers or others, they determined that the reason she was having these attacks was because there was mold in her bedroom. And so they went in, a volunteer organization went in, cleaned out the mold, took care of the problem, and she'd gone like 5 years not without an asthma attack. And so what was being spent repeatedly in emergency departments and sometimes hospitalization was totally solved by doing this one thing at the home. So this is going to be one of the things, obviously, they'll be looking at, are housing, transportation, and other issues around the kind of interaction, personal interactions, et cetera, that may be going on. And that's going to be the 4 top things they're going to be looking at: nutrition, housing, transportation, personal interactions. And they've got a whole list of things that fall under those categories of what kind of services we may want to be providing. I got to put my glasses on because I'm going to. How many of you have accessed this report that came out of the Department of Health and Human Services? It's a review of proposed design for North Carolina Healthy Opportunity Pilots. If you go to the website for the North Carolina Department of Health and Human Services, you will be able to find a number of reports that's been put out around Medicaid reform. And this one, while it's talking about the healthy opportunity pilots, it gives you somewhat of a roadmap of what the whole process we're headed to in social determinants of health is going to be about, because that's what this is. The federal government, as a part of this waiver, is going to give the state of North Carolina, listen to this, $650 million over 5 years to do 2 to 4 pilots in North Carolina around social determinants and how that works. I don't know if you've got anybody working on this up here, and I'm going to tell you a little more about that process. Anybody working on this up here, but I do know, because we're helping a couple other areas in the state in developing proposals. An RFP, they put out an RFI back in February, I think it was. They put out this report in February. And an RFP is going to come out sometime, probably, I'm guessing June, July, in order to pick 2 to 4 areas in the state where they're going to do these pilots. Those areas in the state will be determined that you develop a lead agency, and I know there's at least one council, I think, that is looking to be a lead agency in this. Yep. And so you have a lead agency that's going to have a lot of responsibility in pulling all this together in that region. The lead agency will decide how big the region they're going to do the pilot in will be, and it's supposed to be a part of what kind of reach they think they can have and how they can do that. It's got to be at least 2 contiguous counties, but can be more. But whatever contiguous counties they are, they got to all fall within one of the 6 health regions that's been established by the Department for Medicaid Reform. And so you've got a western region, you've got an eastern region, and then you have basically 4 regions in between that make up 6. And these are the regions that were established for purposes of the provider-led entity applications, et cetera, in the state. So the process is going to be, you need a lead agency. They have to make sure they have plenty of primary care or other case management in place. The monies are going to flow through the 6 or 5 area managed care organizations that will be administering in the state. And then the lead agency has responsibility for recruiting a slate of human services organizations to provide the services that's going to be necessary. Okay. So basically this talks about how they do it. You can go see the RFI also on the department's website and see the questions they ask, and they put out more information. And again, the RFP will be forthcoming soon, with the intent of trying to actually implement the programs by late 2020. Yes?
Mainly focused on women and children?
No. The way this will work is that the lead agency, working in coordination with the managed care company organization, is going to help, and in the RFP they'll be doing part of this, is going to help design what kind of service you're going to offer, and you've got to have at least one, and what kind of people you're going to serve. The services they're going to look at in these pilots is intended to be things that they will really monitor, get data on, to help develop what best practices can be. And part of that's going to be, okay, what kind of people are we going to try to help? So it may be an aged person with some kind of chronic condition. And if that's one of the classifications of people we're going to use, then we then look and say, okay, well, what kind of services might we offer them? So the case manager, the primary care doc, public health, whoever it may be that comes in and sees this, says, okay, we really think that this person could be helped if we could provide them with a better transportation system or better food. And it's not just while we have Meals on Wheels, those kind of things, which serves a great purpose. Some of these may be medically designed meals. So it's not just what you're making that day, it's a meal designed to meet the needs of that individual's health situation. It may be a housing issue. It may be building a ramp for someone to get in and out because they can't get out of the house. It may be a mold issue. It may be whatever that could be done there. Or it may be dealing with personal interaction, which means they know they may be subject to abuse, be it mental or physical, or something else going on that they've got to deal with. So developing services and finding the right human service organizations that can provide these services around this. Then what happens is someone comes in, their case manager, their primary care, advanced medical home, public health, whatever. They evaluate and they say, we really think this person could be helped with this. So you're tying a particular kind of issue they have with a particular kind of service or services they may need. The PHP, the prepaid health plan, or the managed care organization, is ultimately going to decide, okay, who are we going to do this for and who we aren't. So they're going to establish some standards. Word just slipped my mind. The folks that are the lead agency, is going to be a part of helping design these. We'll meet constantly with the case managers and the insurance companies to try to make sure this works. So from the time we start over the period of the 5-year funding, we will be looking to see who out of the Medicaid population gets the greatest benefit from this and what services help them gain that benefit. And so that's going to be what the pilots are all about. Now, most of these managed care companies that work in other states may be already doing some things. And so out of their own profitability, or out of that 89% of their regular funding, there may be some things that they will already start doing. The pilots are really designed to really focus and gather data to help decide what is best practices, what gains the best with respect to improving health and the best with respect to cost efficiency and controlling costs. So as human services organizations within this report, they talk about the lead pilot entities have to determine what human service organizations they need in their mix to make it work. But the department and the federal government states, okay, what's going to be the qualifications for a human services organization to participate in these pilots? And I'm just going to quickly tell you the bullet points. One, the organization's got to demonstrate capacity to provide the services and the commitment of delivering high quality services to support improved health outcomes and whole person care. So if you're going to provide a service, are you really doing a good job of the service? That the services are delivered timely. That there's a demonstrated readiness to participate in the pilots and effectively serve beneficiaries with complex health, behavioral, and social needs. That their staff is educated and knowledgeable. That their hours of operations meets the needs of the pilot beneficiaries. That there's physical access and accommodations for individuals with disabilities. They have cultural and linguistic competency, non-discriminatory practices. They're licensed and accredited as required, demonstrated history of responsible financial stewardship, and willingness to comply with all the reporting and oversight requirements. Many of the things you may already do, but it would be things you'd have to do to participate in the pilot, and probably that what you'd have to do to participate in the program going forward. One of the big differences, a growing difference, let's say, in the Medicaid managed care we're going to have and what we've had in the past, and even the behavioral health world, if you serve any of those folks, the LME MCOs, is we're starting out as a any willing provider operation for the basic services under Medicaid. But the state has already laid out like 62 quality issues, quality requirements. The quality requirements they issue actually are quality requirements for the managed care plans. Things they have to do about in prevention and other kind of things. That 62 does not really to any great degree relate to aging, because aging's not coming in right away. So there will be some other quality requirements that will be brought in. So these are requirements that the insurance companies have to comply with in order to get their dollars continue to flow properly, or otherwise they could be penalized. So then the insurance organizations are going to have to make sure that the requirements for providers are going to make sure they can meet their requirements. So they kind of trickle down. And that's one of the issues, because any willing provider in the in the group can be get into the program, but if they don't maintain their quality issues, that's the one way that the insurance organizations can remove a provider from their network, is the failure to meet that, or just can't work out a contract.
I have a question regarding reimbursement. I assume through contracting, the state capitate rates as far as the maximum rates for the reimbursement, and the managed care companies come in and then negotiate with the state? How is this process going to work?
The state is developing a basic rate chart, which exists, for what they're already paying providers. And the state is using that rate chart and anticipated utilization, et cetera, and developing a capitated premium rate they'll be paying the companies, the insurance companies. The insurance companies then will, for some providers, must pay at a minimum the rate established in the rate chart. For other providers, it can be negotiated what that rate may be. And keep in mind that if you're in network, you get paid their rate. If you don't sign a contract with them and you're out of network but they provide a service, they get a discounted rate. So it's not like they won't get paid, it's just they won't get paid as much. So except for hospitals, physicians, and I forget who all's on the list, and this only goes for the first year, that they have a minimum rate they have to pay. But as the insurance companies develop their networks of providers, they have to meet a readiness review, I think in August, to show that they've been able to put together a network of providers that they can meet the needs of the Medicaid population and they don't have gaps in coverage. And so basically they have to negotiate and get people to sign up. If you have in an area 10 organizations that provide the same services, then they're probably going to offer everybody the same services and try and negotiate a higher, or same reimbursement, and try and negotiate a higher level of reimbursement isn't going to work very well because they probably already got 9 others in the area that will do it. But there will be some negotiation, but basically out the gate, they're saying we're going to reimburse at the same level that Medicaid's been reimbursing.
Okay, then the rates that you've come up with, the capitated rates.
For the insurance companies.
Are they based on actuarial studies?
Yep, and they're doing that now, trying to finalize the rate charts. They're still working with the hospitals to try to get them set up because the hospitals are very nervous about signing any contracts with managed care because the state has not yet developed their rates. And so they said, well, we don't really want to sign a contract if we don't know what our rate's going to be. So they're working on that, and then the state's hopefully going to have those rates available by the end of May, so we'll see, and also know what the capitated rates could be at the end of May. So so they will pay the insurance companies a capitated rate based upon what they've determined the rates to be under the rate charts and the actuarially determined capitated rate. The insurance companies then for the first year will have minimums they can pay to certain organizations, certain providers. Other than that, it's going to be based on what they need to pay to have their network of providers together. And then after the first year, they're going to more aggressively start working to develop other reimbursement methods beyond just normal fee-for-service. And most of those reimbursement methods are going to be around value-based purchasing, which means they're going to set goals and standards, quality outcomes, et cetera, that they want, and what you get paid will be based around your ability to achieve those quality outcomes. We're going into a different world for another reason as we go into Medicaid managed care, and this is going to make technology important and the health information exchange the state's trying to set up and all these kind of things, and analytics and data, simply because it's not, we are going into a whole person care environment. And so it's not how well particularly you do in what you're doing. Obviously they want quality, but it's how what you do helps improve the health and control the cost in a larger picture. So in the services that a provider has, it's going to be looking at how can we, let me just give you an example. Okay, say it's in a home health or assisted living, where we got aging individuals that may have some chronic issues, whatever. Then it's a matter of, okay, how good a job do you do in making sure their medications are there, and making sure they do the things that they need to do in order to control the chronic stuff, keeping them out of the emergency department, keeping them out of the hospital, all those kind of things. Activities, if you're in a assisted living and you've got these social determinants of health, okay, how well are you meeting all those and taking care of them? Or if they're living at home, how does your home health agency or whatever you may be doing for them help in making sure that those standards are met and those goals are met? And so, and to the extent that you play a role in doing that, then that also makes you more valuable to the insurance company. So it's not just I'm going to do my job well and that's all I'm going to worry about. Now it's going to be I'm going to do my job well, but I got to figure out how I intertwine with everybody else that's helping this individual. And the payment will change. So there's beginning efforts by these companies in other states to do and even in the private market to do things around quality and value-based purchasing, et cetera. And in the proposals, they basically, after the first year, which is the period of time that the rates are guaranteed for some providers, after the first year, they got to submit to the department, okay, what's your ideas? How are you planning on transitioning to a more value-based purchasing arrangement rather than just a click-of-the-meter arrangement? And they have a period of time, I'm trying to remember, but I think their goal is over like 5 years, have pretty much a solid transition in the way they do that. So it will no longer be, I get paid for every time I do a service, but you may get paid some that way, but there will be some part of the payment that may result from the ultimate outcomes to be achieved. I think I saw you first, and then I'll.
Thanks. To clarify something you've gone over a couple times when you made reference to social determinants of health. When the concept was originally brought into the public health community, it's a community health-wide concept. In other words, if it's a housing issue we're going to address as an SDOH, we do something to uplift the housing quality for, say, a targeted age community. You're addressing social determinants of health for an existing Medicaid eligible population. So you've got a much more granular, or the department has a much more granular application in mind here. If you're already an existing client who qualifies for Medicaid, we're looking to do things peripheral to the clinical experience that will help you avoid some of the high-cost clinical care. Mm-hmm. But we're not necessarily looking for your neighbors to also be uplifted
in the
or
population,
family members.
in the population health arena, when we talk about population health, we pick up, just like you're saying, and rising water raises all boats. But in this arena,
right,
they're not worried about raising all boats. They're worried about, if this person has a chronic condition, what can we do for this person in order to alleviate that problem and hopefully improve their health and decrease cost.
And that in turn has implications for program design, because
it does.
we're talking about a person almost patient-centric, not a community-centric.
I was wondering who is going to be transitioning the rates? Like you mentioned various criteria for the change after the first year. Who will be determining that?
The managed care organizations will be determining it. And again, depending on where you are, here you'll have 4. Some areas they'll have 5. And depending on where you are, here you'll be working with, again, with Blue Cross, with AmeriHealth Caritas, with WellCare, and with Carolina Complete Health is the regional. That was this Centene, WellCare, Blue Cross, AmeriHealth Caritas, and United Healthcare.
But above them, above the insurance company, there's a state insurance agent, the insurance department, or the...
Which license them, but will not have any issue with rates. The Department of Health and Human Services will have to approve what they do. Pretty much like right now, they're waiting the contracts that they've developed to, each of the companies have developed for providers to sign. The department requires that those contracts, not the individual contracts, but the contract template be approved by the department. They're running behind on that. When I said earlier that hopefully everything starts November 1st, there's a few little things that the department's struggling to get done, and that's one of them. The second one is providers get a manual from these companies of what's expected of them and all that. Again, the department says we got to approve that manual, and they haven't gotten that done yet. So there's several things like that. But as they start changing reimbursement methods and doing those kind of things, I don't know that the department's going to be involved in the negotiation of rates or modification of rates, but as they start switching from fee-for-service into other things, the department wants to know what they're doing.
Can I tag one more question? Is there going to be any consistency from insurance company to insurance company? Are they going to be...
With respect to rates, not necessarily. With respect to quality requirements, not necessarily. They're going to all reflect what the department has, but no, this is going to be one of the challenges for providers, is if you're a Medicaid provider up to this point in time, you build Medicaid. If you did behavioral health, you build your LME MCO. Now you may bill the 4 managed care companies. For those that are carved out, you'll still bill Medicaid. and for the folks that are in the behavioral health more difficult, you'll build what it will become the tailored plan. So depending on who you are, and if you're in multiple regions, you could have 12 to 15 companies to build instead of just one.
So related to that, that sounds really difficult, especially for small agencies that are doing good work. All of these entities are going to have their own criteria that doesn't match necessarily the next entity's criteria, or the insurance company is going to have their own criteria that's not going to match the next company's criteria. Who's going to develop the tools and measurements so that all of the agencies have a common way of reporting?
There will be some consistencies, but there are also flexibilities. I will say that the managed care companies have complained that North Carolina is a little more prescriptive than what many states are. So that their prescriptiveness will create some consistencies. But basically the state's saying we're going to hold the managed care companies accountable. The managed care companies are going to be the ones dealing with the providers. And so there will be appeals processes and all of that are structured in all of this, but the managed care companies each will have, and quite honestly, the companies that are more successful in North Carolina will likely be those companies that have the best relationships with the providers. So there is an incentive to have a good relationship with providers, because then the providers, talking among themselves and everyone else, tell the Medicaid enrollees, if I were you, I'd sign up these folks over here, they'd take better care of you.
But why wouldn't part of this ginormous plan to make this big, like, baseline change to Medicaid for the state involve some upper level determination of here are the tools, here are the measurements, here are the outcomes that you have to achieve. Insurance companies, these are the measurements you have to go by if you're going to control rates and reimbursement rates based on outcomes. I mean, this sounds...
Well, again, right now there's 62 quality measurements that the state has established, but they're holding the managed care companies accountable for achieving those measures. The managed care companies then are going to develop, okay, how do we accomplish those, and how do we then, what kind of requirements from providers? But you know, the managed care company, the whole thing that's going on with this, obviously, is we're shifting the risk. We're saying the state's going to pay an annual premium for each individual covered, and they're taking the risk on whether or not they can actually make this work within that premium or not. And in some states, that has not worked, and the companies have left. So they're doing that. So in giving them the risk, they have to give them some flexibility in how they're going to do it. And so for a company, and I'll give you, AmeriHealth Caritas is a good example. I know these guys pretty well, and they went into one state, and the services they were offering in the behavioral health IDD world became quickly known as the best service. They did the best job with that. So every high-cost patient in Ohio, I think it was Ohio, all shifted over to AmeriHealth Caritas. So all of a sudden they have a terrible adverse selection, and they're losing $25–30 million a month. And they went to the state and said, you know, we want to do a good job for y'all, and apparently we did too good a job, because now we're getting all the high-cost patients, and we need some kind of adjustment to our rate. And the state said, no, you raise your rate. So they just pulled out mid-contract. They said, we'll go bankrupt if we stay. So they try to give flexibility, and they learned their lesson. They probably won't be as generous in that area anywhere else they go. But in South Carolina, they are the largest Medicaid managed care company in South Carolina, because the providers liked what they did, and the providers have encouraged folks to become a part of that. So I don't know what's going to happen in North Carolina. Blue Cross Blue Shield's, the name wins a lot. United's been in North Carolina for a while, but so you've got that happening, but they're going to have some flexibility, and in developing what kind of criteria they have, they can remove a provider for not meeting criteria, but they must demonstrate that they were non-discriminatory in the way they did it. Meaning they can't just pick out a provider that isn't meeting the criteria if they got 20 others that's not meeting it as well. So it has to be demonstrated to be non-discriminatory if they're going to remove a provider for that purpose.
Can you speak to Maximus at all, and what that is?
Maximus? Maximus is the vendor who won the contract to be it's kind of like the navigator, the enrollment broker. And so what they do, what Maximus will be doing is you still will go currently to local Department of Social Services or to a social worker that works in the hospital or whatever to get enrolled in the Medicaid. That's the enrollment. Then the job of Maximus is to talk to that individual, find out what their health issues are, and help direct them to the plan that probably best meets their needs. Again, like in Ohio with AmeriHealth, they were best meeting the needs of a certain population. And so Maximus will help you select a program that would probably best meet your needs with their provider network, whether your doctor's in their network, et cetera, et cetera, et cetera. And that will be their job. Nationally, 20-25%, I believe, is the number that I've heard actually enroll in a particular program. The rest of them are auto-assigned because they don't make a decision.
Behind you. These have their hand.
Okay, sorry.
So I was curious with the person-directed service for all of those social determinants of health, our provider, how do we qualify providers? So if we don't have capacity to provide safe transportation or housing, and those are two of the indicators or things that we're really trying to get after, and we're just putting them on another wait list, how can these plans invest in training new CNAs, having additional transportation options? And if that's not, if we're still really person-focused and it's just the case management to programs that don't have capacity to meet those needs, how is the state, because I imagine the state is saving money, how are they coordinating investment efforts in those areas so these projects can be successful? Or is that on their radar?
The state's saving money. I mean, basically the money that's been appropriated is probably going to be substantially allocated in the capitated payments to the insurance companies. But the pilot programs we're getting ready to do, a big part of that is helping us learn how to do that. And again, Western North Carolina, and all my years' experience with Western North Carolina, is very innovative in doing things, and I'm wishing that maybe y'all find some way to participate in that. But anyway, in the pilots, whenever you have a lead pilot agency, their responsibility is going to be identifying human service organizations that can fill these pieces. Now, in the pilots, they don't have to fill all 4 of the pieces. They have to file at least one, but the department's hopeful that they fill all 4 of the pieces. And so you find organizations do it. And in the initial pilots, while ultimately all these human service organizations may become Medicaid providers, it's not necessary that they be an enrolled Medicaid provider to participate in this program. If the lead agency and the PHP say, yeah, they do that, they just have to meet the criteria in order to participate. When you put $650 million into the state over 5 years, which is going to be, what, $125 million or so a year, to go into 2 to 4 pilots around the state, my experience is, as a CPA, that when there's money out there, the opportunity is seized and organizations come around to be able to provide the services. One of the challenges we've had is the limited source resources. So the pilots get us to help us decide what works best, who can we assist and gain the greatest benefit from, both from a health standpoint, quality of life standpoint, as well as a cost standpoint, and develop that. And then the expectation is that once we've got that data and we know how we can really make this work, then it becomes a part of the overall Medicaid program. And likely will filter into other areas of insurance as well. Medicaid will be the test pilot for some of this.
So outside of the pilots, there wouldn't necessarily, so investment in education for CNAs wouldn't be a provider that...
The plans could, they just will not have designated funds to do it with.
Okay.
They will manage these funds, but these funds will be focused on that pilot project, and with the lead agency and everyone being totally involved in it.
I'm interested in whether the Division of Health and Human Services, or I'm not sure who the players would be, are connecting this transformation directly with conversations in communities, for example, around affordable housing. It's a big issue here, you know, in a lot of parts of the state.
Mm-hmm.
And we have affordable housing related efforts going on, but I don't necessarily see where they're connecting to housing as a social determinant of health. And I'm just wondering if you could.
Yeah,
that
and as previously mentioned, this is, while this will impact population health, this is more a focused effort as opposed to a population health effort. So these funds will not be focused on that. But just let me give you a couple ideas here. And again, if you get this, you'll find it interesting because it really gives kind of a roadmap to this. And it was released in February of 2019. It's called North Carolina's Healthy Opportunity Pilots and what they're proposing to do. But there are opportunity pilot services that are, in anything they do with this money, feds have to approve. And so they made a list of things that fall under the housing and tenancy support services. Assist individuals identifying preferences related to housing, type, location, living along with someone else, whatever. Supports to assist the individual in budgeting for housing, living expenses, including financial literacy education. Now, some of these things housing agencies obviously already do. Assist the individual to connect with social services to help in finding housing necessary to support the individual meet their medical care needs. Assist the individual with housing application and selection process, including filling out a housing application and obtaining submitted. Assist the individual to develop housing support plans. See, everything is based on individual. So while they do have assist the individual from eviction by providing services, improve his conflict resolution, et cetera, they allow potential dollars to pay a deposit and first month's rent to get them into a place. Again, when it comes to housing, there's a page, almost 2 pages of things that can be done, but building affordable housing or whatever in a more global nature is not it. It's all focused on improving the health of a Medicaid individual.
Just a quick follow-up question. Are you familiar with the CRASH program in Vermont?
No. I'm coming back to you.
I need a little help figuring out how 2 big things you described line up together and work. On one hand, we've got the state of North Carolina through HHS is launching a capitated program, essentially a Medicaid Advantage program through 4 carriers, right?
Mm-hmm.
And
5 actually, 4 statewide and 1 regional.
Okay, right. And that is not going to affect older adults, dual eligible types.
Initially, yeah.
Correct.
They'll
until a certain date.
start phasing them in probably 2021.
Right. Now, meantime, setting that aside, parking that, we've got a federal pilot project through CMS with $650 million coming into North Carolina to seed 2 to 4 projects to help create an understanding of cost-effective approaches to this. But if those are going to address older adult health, they have to be done with a lead agency that's going to work in tandem with one or more of these 5 carriers.
No matter who in the Medicaid population it addressed, they got to do that, yeah.
But
And it's not limited, just older.
If the first is not going to address older adult health for at least a year or 2,
Well,
how's the...
it could.
The pilot will force it, I think, right?
It could, simply because it's a part of the 1115 waiver, and I haven't heard the specifics of this, so I'm not going to say it absolutely will. I'm just saying it could, because of the fact that you create the lead agency. The money is going to flow through the prepaid health plans, the managed care organizations. Yeah. You're going to be using the case management folks that you have, and they've got to develop that. But keep in mind that even though the PHP may not be paying the expenses of certain populations initially, that Medicaid still is. And it's still a benefit to Medicaid, even though it may not be a benefit to individual PHPs. But also keep in mind the timing. Yeah. Is they hope to begin this pilot by late 2020.
Yeah.
And it's probably going to be in 2021 that I'm thinking that we start phasing in
Right.
the dual eligibles and others. So in developing the pilot, it's still got to be developed in preparation, because the pilot runs for 5 years. It's got to be developed and taken in preparation for that population coming in, even if they're not in managed care at the initiation.
I still have trouble making those ships parallel park together. Okay. Yeah.
Somebody else was over here.
I have a question about, you keep mentioning case management. So, for instance, our agency has mental health and case management, but we can't bill for case management if it's not clinical case management. So we're talking about capacity, right? We could have greater capacity to do more case management with more people if there was funding for it, but it sounds as if there's not. You just have to say, yes, we can see more people for that, but there's no way to bill for it.
There is, I believe, and I should have had my technical people here for this, but it is, I believe, funding for case management, but the case management is going to be focused a lot around, now there's arguments right now about who can and can't do case management. We know the advanced medical homes will do case management. We know there may be some public health that can do some case management for their population, which is still may be primary care. And there's some other classifications. But like right now with the LME-MCOs, VIA, they want to do some case management. It's still not determined whether or not they will be able to do that. So what's going to happen over the next 6 months as we approach November 1, and I've even had this conversation with the Deputy Secretary at HHS over Medicaid, they're still trying to figure some of this out. And they're working with the managed care companies and others on how they're going to do this. And there's still a lot of unanswered questions about operational and how this is doing. And those are some of the challenges that if, other than the protest against the awards of the contracts, if there is anything that slows down implementation, it's going to be the inability to address all those challenges. I think they're going to get there, because politically it's not good going into a gubernatorial election year to not get something done on the timeline you say you're going to. It's also not good to try to implement it and it goes south. But it's going to be, the next 6 months will tell us a lot.
I have a quick question, and kind of predicate this question on the fact that I do some work with some behavioral health organizations in town, and the Blue Cross and Blue Shield private insurers are like the absolute worst payer, and they have tactics, denial tactics that are arguably illegal, but anyway, we struggle with that. So I'm curious. I feel like I've heard you say that a Medicaid enrollee would have the option of shopping around to their managed care company.
Which
if
plan?
they didn't like the services that were being provided by one, they could presumably go to another, and that with that, the provider could encourage them to say, this one is not as good as this one. We really like this one. Go work with this one. So I wonder, sort of with that ability to shop around, can the provider, is there any recourse against the provider who says, opts out and says, we're not going to accept United Healthcare because they're just notoriously bad and we don't like working with them, but we have a great relationship with Blue Cross, and so we're going to work with them only, and we're going to encourage you to switch over. Is there any prohibition against that from an organization to do that, so far as you know?
Providers don't have to sign up with all,
Okay.
And there will be some that won't. They have to, but if you're out of network and someone comes to see you, then and they like the company they're with for whatever reason, because all the rest of their doctors or whatever are in that company, then they will get a discounted reimbursement. I think it's like their normal reimbursement less 10% or something like that, but it's an out-of-network reimbursement. But yeah, it could. So they will choose as they come into the program, or once a year they will choose what plan they want to be in, and I think they have the ability to change plans once during the year if they need to. But the broker Maximus should help them choose which plan will best meet their needs by the network of providers. If there's an area that they offer some things, like some plans may offer some things around social determinants, the other side they're not going to do, because some plans may have done it in another state and seen that it worked well for what they did in the other state, but the company may not have had that experience. My guess is once we go through this 5-year of pilots and we see what really works well, they're all going to want to do it. And by the time we're almost finished with the pilots and hopefully have a lot of data, because their intent is to generate data the whole process and not wait till the end, as we move into the second round of RFP and selecting companies, because it is probably going to be like a 4-year contract. The waiver, I think, is for 5, and so we have to redo the waiver, make some changes in that, and in doing so, we may take some of the best practices we learned in social determinants and put them in to mandate that the companies do some of it. So, again, we're in a real learning phase, and we're doing things here that other states have not done. Really focus on social determinants. That's why the reason we had the pilot. We were trying to do more things in telemedicine, telepsychiatry. We were trying to get some other dollars available for housing. This pilot's going to help us build the case for some of the other things we want to do over time.
So, speaking as not our service provider, but a person who might use the services, how, it doesn't sound optimal for an individual, you know, because it all seems to be predicated on you know, this, on the networks and the insurance providers, which hasn't historically necessarily benefited the individual. So what's going to be the mechanism for getting feedback?
Well, most of the companies are going to probably have some panels of folks, meaning some consumers and others that's going to provide impact. But you got to think about this a little bit differently than what we have in the normal insurance market. The normal insurance market, they provide the services, they do the advertising, they try to attract you in, and if the money's not working out well, they may cut service a little bit, but they also can raise their rates. The rates here, the legislation that created Medicaid reform in North Carolina set a goal of making our programmatic growth, budget growth in Medicaid 2% below the national average, which actually we accomplished during the depths of the recession while I was, not because I was secretary, but we accomplished it. It was the revenue rate, federal rate match that caused all the budget problems. But anyway, so the way that they generate more revenue is increase their population base they serve. And the way they do that is by they'll either try to attract certain populations or in how they work with providers, et cetera. And they don't want you, if you come in, that's a monthly amount of revenue they get, and they have an incentive to keep you in, and they're not going to keep you in if they don't at least try to address. Different companies are going to do the things they do best. And so, and the benefit of the enrollment broker is trying to identify, if you have certain conditions, what best suits you. It doesn't mean you can't go to one of the companies, and some people just say, well, I don't care, and they just get assigned. But that's going to be the process and how they get assigned. And again, 80% or so of the folks normally just get auto-assigned, and that works well for the companies. But the companies can gain more population by how well they deal with that, and a lot of them will do satisfaction surveys, do things like that to see what they can do to do better, because they can't raise their rates. The only way the rates go up if actuarially the state decides to increase them. Over here.
So we have about 15 minutes left in the conversation, but so I was talking about adult daycare funds before we started, and that those adult daycare reimbursement funds are technically Medicaid money, but the people that receive those don't necessarily have to be on Medicaid. How will that work going forward? And I know that answer.
And I don't.
So currently, those funds are given to the county. The county tells an agency like us, you have this many dollars to spend, and then we contact the social worker who signs somebody up. And again, they don't necessarily have to be on Medicaid.
And I don't know.
So
I do not know the answer to that question, sorry. But I do believe that as we move into this new area, some of the social determinants may be beneficial to you, but I'm not sure exactly how that will work.
First of all, one question just went out of my head, so I'll go with the next question. It's really a statement. I'm wondering kind of how the decision was made to delay older adults and disabled when by 2029 we will be 20% of the population, and if you don't begin immediately, sort of, I don't want to say a bad word, but like climate change, if you don't do something now, by 2029, the problem is going to be huge. No.
Yeah. Well, the reason they've staged it coming in, you know, 75% of the Medicaid population is women and children. About 20%, 25% is aged and disabled. Aged and disabled is a more difficult group to take care of and more expensive. 25% is aged and disabled, they're 75% of the Medicaid budget. 75% is women and children, they're 25% of the Medicaid budget. And so the deal is the department made the decision that, okay, we want to transition the easiest group first.
Less money at risk.
Transition the easiest group first and make sure we got our networks together, make sure everything's functioning the way it should, and then we'll begin transitioning the others, probably by region. They haven't said exactly, I don't think, how they're going to transition the others. In the behavioral health world, all of the mild to moderate cases of behavioral mental illness or substance use are going to transition with everybody, with the women and children, if they're in those categories. And then they'll start managing those Medicaid dollars that the LME-MCOs currently manage. But the rest of the population stays with the LME-MCOs until the population transitions or until they become tailored plans.
So, I remember the other question, it's a point of clarification. Right now, in terms of private insurance, there's generally one carrier per region, not because they kind of, I guess, self-select. I'm not really sure about that, but typically we've had either Blue Cross, Blue Shield, or United in this area. You're saying now for this experiment, all 4 of the statewide HMOs will be operating in all, they'll be viable in all areas?
Yeah, technically the transition to Medicaid is not an experiment, it's done, although it is under a waiver that has to be renewed. But yes, you will have United opting for, looking for enrollees, you'll have Blue Cross looking for enrollees, you will have AmeriHealth Caritas looking for enrollees, and you will have WellCare looking for enrollees.
And they all have to go, all those enrollees have to go through the navigator?
Through the broker, yes, they will all be. And so that's a part of the transition. That people will start actually that process before November, because when November 1 comes, you basically have to have your enrollees in place. But they're looking to do the readiness reviews of the companies to make sure the companies have the provider networks in place to serve those folks.
And you know there was a huge criticism of the Affordable Health Care program when there weren't sufficient people to enroll people initially, so ironically enough.
And I'm sure there's staffing requirements for Maximus, which is a company that's done a lot of consulting with the states over the years, but I don't know exactly what the details are of that. Yes, sir.
One of the more expensive groups is women of childbearing age. And you're starting out with young people in that category. So you're not necessarily taking the least expensive group.
And a part of the, yes, almost 50% of all the children born in North Carolina are born under Medicaid. And it's expensive, but not as expensive as long-term care and all that kind of stuff. And a part of the social determinants in the pilot is that's a group that they've got specific groups they're looking at, or types of patients they're looking at, and one of them is a pregnancy where they have some kind of history of issues that could lead to early delivery or chronic, or have a history of some kind of family violence that could impact the pregnancy, cause high blood pressure because of stress. I mean, there's really a lot of thought, and I encourage you to go online and get that report, because it'll give you a good insight into where this is going, and you'll get some better idea if you look through the whole report of how you may fit into it. Yes?
So the pilots are kind of defining best practices and establishing those networks. And then after that 5 years ends, how will they, so there'll be contracts between the lead agency. moving forward, every agency would just bill for the services they provide, or will there be some reoccurring MOU?
They're probably going to, and again, this is conversation that's gone on. And again, keep in mind, when we do the 1115 waiver under which all this is happening in North Carolina is like every other waiver granted by Medicaid. It's a 5-year waiver to which you have to go back and get it renewed, and you can modify it, et cetera. The CAP programs, all that are waivers that keep going back for renewal. So it's the same thing with this. And so this original pilot kind of goes over that same period of time. And so what we learn from that will probably somehow be introduced into the next, my guess. No inside information on that, but that'd be what I would be looking to do. And so we'll be doing that. But the payment for how they do this in the pilots, and keep in mind, again, it doesn't mean that if you don't have a pilot, nothing's going to happen in this arena. It just means if it does, it's something that the insurance companies decide to do. But what is they're talking about is, again, rather the click of the meter, it may be a bundled payment. Okay, we have this individual, we got all this, I'm going to pay you this, and your job is to take care of them. Or whatever. So it's not necessarily going to be a click of the meter kind of thing. As a part of the pilot, they're going to look at, okay, how do we best reimburse? Because they are interested, if they've got good providers of services, they want those good providers of services to be financially stable because they want them there over the long haul. And so as they start doing this, they're going to be experimenting about how best to make that work for those who provide quality services and make it work.
This is also just a statement. My brain likes to latch on to things and understand, so it feels a lot like Medicare Advantage plans for Medicare people. Would you say it's similar to that, in that they can provide services, it can provide higher level of services or less, and you get the opportunity to change your plan during the year one time?
Have somebody help you.
It's a capitated program.
Mhm.
Yeah.
Mhm. Yeah.
Structure.
Yeah.
I recently went to the North Carolina Public Transit Association conference in Wilmington. We had an opportunity to sit with the transportation providers for everybody was there with Blue Cross. So we had an opportunity to talk to them about what this is going to mean for transportation providers, especially those small rural counties that only have one vehicle, or they only have, a very small fleet. And there seemed to be a lot of, well, we're trying to get there. I am concerned about the transportation piece. Can you speak a little bit more to how we're going to be expected to meet those standards? I mean, because obviously some community transportation services, because we're state funded, are going to be differently regulated in general than an Uber or a Lyft. And how is all that going to work into the reimbursement and that kind of thing?
My understanding is that there are a lot of counties, obviously, that provide those kind of services. There are some counties I'm hearing are ready to get out of those kind of services. The managed care companies generally have a vendor that they contract with or have a division within their organization. I think United has their own vendor that they acquired as part of them. Logisticare does United. Well, I know Logisticare may be used by more than one of them then. And they basically contract with them in a subcapitated way that their responsibility is to make sure there's access to those services. Those companies, most of the time, will find local vendors that will do it, but they're going to have to negotiate the rates and how that's going to work. And it may be that if other services aren't available, they will use Lyft or taxis or whatever it is to make that happen. But basically, the insurance companies have a requirement that they have access to local transportation for Medicaid purposes, and that whatever companies they use are going to, and most all of them have done it in other states, are going to have to develop that. So if there's nothing there, they're either going to have to develop it, get someone from another county to expand and put some vehicles in a different county, whatever, but that's a requirement of the program, is they have a network of transportation.
It seems like in that tier of things, insurance company, managed care, like, for example, United Healthcare, Logisticare, and then the money, it's like the money is going to dry up before it gets to, because right now, the individual calls, we provide a trip. It's incredibly simple. It sounds like we're totally complicating something that has been has worked. I mean, I think we can always do better, but it sounds,
Yeah.
anytime I think you put multiple layers in, it separates the individual from the person that they're actually dealing with. I think it complicates matters.
I spent 14 years in state government. That's what we do. Well, you know, when I was secretary, Logisticare came to the state and wanted to do a contract with the state to manage transportation and promised the state, I don't know, $1.5 million annual savings. And the main reason we didn't do it was concern for the counties. Well, now we're going to managed care, and the legislature's kind of passing on this issue and saying, well, we're not responsible anymore. You got to go talk to the managed care companies. The managed care companies have a mandate of what they got to provide. Individually, the managed care companies do not have the capacity or infrastructure to do that, so they get a contract with someone else. So you got to have a vendor that has certain requirements, and they're going to have quality requirements, I'm sure, of what they've got to do, having access, wait time, whatever. And under the social determinants, the definition of non-medical transportation will expand. A part of the problem we had with counties was taking people and dropping by other places that were not Medicaid related but still charging for Medicaid. And we knew that was happening, but well, now you got to have these companies that are going to be much more restrictive and with oversight to make sure that, yes, we're going to pay you for the non-medical transportation, but it's got to be specifically for what you're saying it is, which is going to place some, I'm sure, some limitations that maybe haven't existed in the past. But with the social determinants, it may be that stopping by the grocery store to get nutrition becomes a part of what we're going to pay for, or making other kind of stops related to the things we're trying to manage under social determinants will become a part. So we could see some expansion of what they're really allowed to do as we get better, what's going to really help these folks achieve their goals.
Final question.
Would you be available to help us write a grant for the pilot?
We are working with a couple other organizations to do that, but if you're interested in doing something, the first thing you got to do is figure out who the lead agency is going to be and look to see what the requirements of being a lead agency are. If you look at that and you think it's something you want to pursue, then call me and we'll figure it out.
Thanks.
Expect a call tomorrow.
Thank you so much.
Thank you. This is fun. I enjoy coming back. Thank you.